Good morning, good afternoon, fellow HUD employees. My name is Simone Little with Ochiko, and on behalf of Ochiko, I would like to introduce you to Dwayne from FOH, who will be introducing our key speaker today. I hope you guys enjoy. During or after the presentation, we will be taking questions if you need to know further information about our program. Thank you and welcome, welcome.
Good afternoon, ladies and gentlemen of the audience. Thank you for attending. This is Thyroid Awareness Month, as you are well aware of. And we have a wonderful guest speaker this afternoon. Her name is Dr. Jennifer Rosen, and she'll be providing this information to you. Just a little brief bio blast on her. Dr. Rosen is Chief of Endocrinology and Endocrine Surgery and Vice Chair of Research of the Department of Surgery at MedStar Washington Hospital Center. She serves as the Collaborative Endocrine Surgery Quality Improvement Program Committee of the American Association of Endocrine Surgeons and sits as a representative of the College of Commission on Cancer, a program of the American College of Surgeons. She has been active on numerous committees of the American Thyroid Association and serves as endocrine sections editor of the Journal of Surgical Oncology. Dr. Rosen specializes in the surgical treatment of diseases of the endocrine glands, including the thyroid, parathyroid, and adrenal. In addition to surgical techniques, Dr. Rosen works closely with endocrinologists, nuclear medicine, and radiologists in order to determine the proper testing as well as best treatment options for each patient. Dr. Rosen received her undergraduate degree from the University of Pennsylvania and her medical degree from Thomas Jefferson University Medical College in 1997. She then completed her residency training in general surgery at Beth Israel Medical Center before completing her fellowship training in the surgical oncology at the National Cancer Institute in 2005. Dr. Rosen's practice utilizes laparoscopic approaches to the procedures of the adrenal gland and minimally invasive thyroid and parathyroid surgery techniques. She also uses nerve monitoring, intraoperative parathyroid hormone measurements, intraoperative ultrasound, and 4D CT scan for localization of abnormal parathyroid glands. These techniques allow Dr. Rosen to offer more precise surgical procedures through smaller, less invasive incisions. She is truly an amazing and gifted talent to the world of medicine. And speaking of the world, we're not advocating for the development of research infrastructure at MedStar Washington Hospital Center. Dr. Rosen enjoys spending time with her 3 children, gardening, knitting, and practicing yoga and traveling. A truly well-rounded person. So now, after that brief bio blast, please give your undivided attention to our guest speaker, Dr. Jennifer Rosen. Dr. Rosen, you have our attention.
Thank you for your very kind introduction. And also thank you for the opportunity to come and talk with you today. Honestly, I love what I do, and I'm deeply fortunate to be able to practice medicine. I'm deeply fortunate to be a surgeon, have wonderful colleagues, and I'm also very, very glad to be a part of the American Thyroid Association, the American Association of Endocrine Surgeons, because I get to talk with other people about what we love to do. So the first thing I'm going to say is thank you for the kind introduction. And for the most part, I think we'll hold off on taking questions until towards the end. If there's something really burning that you want to ask, please get up. But I'm willing to bet that many of your questions will be answered, but not all. And we'll have plenty of time at the end to answer questions because I love questions, especially because it challenges what I do and challenges how I think about it. So as I mentioned, the American Thyroid Association was part of helping put together this event today. It really is the largest and best organized group dedicated to the study of thyroid in the Americas. And it studies thyroid biology, and it's dedicated towards preventing and treating thyroid disease in patients. They have a yearly meeting. I go to it every year. I'm very active in the organization, and we welcome all kinds of allied health professionals and patients to many of our events. So I am Chief of Endocrine Surgery and Vice Chair for Research at MedStar here in DC. My disclosures are really, I have no commercial disclosures, just that I have had research grants in the past funded through a variety of means. But most important, I have a deep and abiding love for what I do, and I really love complex problem solving, and I love taking care of patients. So, as you may know, January is Thyroid Awareness Month, and we're going to talk today a little bit about thyroid disease, more specifically about thyroid nodules and about thyroid cancer. So we're going to talk with you a little bit about how we think about patients and taking care of them, about how we make the diagnosis and make decision treatments along with people, how we think that we can do better at what we do, and then, of course, what's going to happen in the future in how we think about and manage thyroid. It's a moving target, believe it or not. Thyroid disease is incredibly common. I don't need any of you to out yourself, but raise your hand if you or a family member or someone close to you has had a thyroid issue in the past. So about 80 to 85% of the audience raise their hands. That's pretty typical. Thyroid disease is incredibly common. More than 12% of the US population develops some kind of thyroid conditioning during their lifetime. And many of the patients that we see probably have had symptoms or something related to the thyroid going on for a while before it was discovered or found. That's not uncommon. This is a busy slide, but we're going to go through it because those are points I want to make sure that we cover today. So women are far more likely to develop thyroid issues, and in particular thyroid cancer. We don't know why that's the case. And 1 woman in 8 will develop a thyroid disorder sometime during her life. Many of the thyroid cancers or patients with thyroid cancer we see respond well to treatment, but a small proportion of patients can have a very aggressive form of thyroid cancer. And so seeing somebody who knows what they're doing and knows how to take care of thyroid disease is really important. The causes of most thyroid problems are really unknown. In the United States, the vast majority of patients I see with thyroid cancer, we don't know why they develop thyroid disease. Undiagnosed thyroid disease can progress, and it can cause all kinds of other serious conditions if we don't treat it. We know that treatments have their pluses and minuses, but certainly if it goes untreated, we know that we're going to have other issues as well. Pregnant women, very often we see them late on, and it can result in all kinds of complications, either infertility or difficulty with pregnancy and delivery. And really, I think I'm fortunate because I treat patients with thyroid disease and thyroid cancer. I'm there for a very important time, the thyroid surgery. I'm often there for the diagnosis portion, and I'm there for the lifelong management of these patients. So I really think of it as taking care of the whole patient, which I really like. So just as a reminder, the thyroid is a gland in your neck, shaped like a butterfly. It's right around some very important structures, including the breathing tube called the trachea and the swallowing tube called the esophagus, the major arteries that go up to the brain, important nerves that run through this area, and it sits like a hand around your throat, right in a very vital and important area of the body. So what does the thyroid actually do? Well, the thyroid makes thyroid hormone, and you need that thyroid hormone for pretty much everything in your body to function properly. You need it to use energy, to stay warm, for your brain, heart, muscles, everything essentially to run on time. Basically, you need your thyroid or some form of thyroid hormone supplement to live. And many of my slides are really more of a pointer to make sure I cover an important part of this for you. There will be no quiz later, but these are the things that I think about and how I think about the thyroid. So this is thyroid anatomy. Unfortunately, my pointer doesn't work, but what you're looking at basically, circled in blue are the important veins, circled in red are the important arteries, and down below are 2 important nerves. And the most important thing to tell you here is those nerves are the nerves that go into your voice box. They help you with swallow and they help you with voice. Most patients I see with thyroid cancer, those nerves are perfectly intact, but the thyroid lives immediately on them, which is why it makes the surgery or the surgical approach so challenging. So I'm not a book learner. I think of things in terms of patients, and I think of things in terms of patients I've taken care of. So I'm going to tell you today about some patients that I've taken care of. I could pick 100 examples to talk with you about, but we don't have 100 hours, even though I would be happy to talk for 100 hours. So this is a patient who I saw. It was a 35-year-old lady who came to see me with thyroid nodule. And it had been noticed by her primary care physician on a routine visit, although the patient said she might have noticed it a little while before. She really has no symptoms. Her thyroid is functioning normally, and we'll talk about what that means. She has no really interesting, significant, or pertinent past medical history or family history, no history of radiation exposure, and again, no voice changes, no swallowing issues, nothing at all. The only thing that was noticed was this nodule in her neck. And this is important, and we'll talk about why each of those points matters to patients and matters to the physician, because if the answer was different, it would change how I approach and treat her. Oh, did that skip? Yeah. So a significant number of patients have thyroid nodules. If I were to do an ultrasound of the thyroid of every one of you in the room, I'm willing to bet somewhere between 5 and 10% of you would have a thyroid nodule. But the vast majority of those nodules are completely benign. Only a small proportion of them are going to be thyroid cancer. So as you can imagine, it's very important for me to be able to figure out who does or doesn't have a nodule that needs to be evaluated and whether or not it's like to be a cancer. Because otherwise I could be very busy from morning till night operating on patients just for nodules alone. So we need to know what that nodule is. And by the way, a nodule means a lump or a growth within the thyroid. Okay? When the patient comes to see me, I'm going to do a complete history and physical exam. There's a reason for every one of the questions that I'm going to ask you. I ask about radiation exposure because radiation exposure in a significant way increases your risk of developing thyroid cancer. Now, we're not talking about the x-rays that your dentist does or the mammogram that you get routinely or an x-ray you had for asthma as a child. We really are talking about this significant amount of radiation. Radiation treatment or exposure to a nuclear event or maybe routine exposure at work. And then family history. Well, why does family history matter? Because there are certain kinds of thyroid cancers that do run in families or are more common to run in families. So if you tell me that your mother and your sister both had thyroid cancer, then I'm going to look much more carefully at any of your nodules, and I'm also going to ask to screen the rest of your family. I'm also going to think about some of the more uncommon forms of thyroid disease. I ask about symptoms because symptoms are worrisome. If you have trouble with your voice, trouble swallowing, or signs or symptoms of over or under function of your gland, and we'll talk about those a little bit, it is going to change how I approach working you up and also going to make it a little bit more likely that I'm going to do a couple more studies before I send you for evaluation. I'll ask your personal history. Some patients have had thyroid operations in the past, or some patients have had other tumors or growths in other parts of the body that, as it turns out, are related to thyroid cancer and make it more or less likely that you have that. And of course, I'm going to do a complete history and physical exam covering you top to toe. I always ask patients about screening. I make sure they're up to date on their pap smear, colonoscopy, mammogram, anything else that's appropriate, mostly because it's an opportunity at that time to make sure that they're doing all the things for their health that are important. And then I'm going to get a blood test and an ultrasound. And we'll talk about what those are and why I do those. When you see someone who's a thyroid specialist or takes care of a lot of patients with thyroid disease, we're much more efficient in what we do to work you up. I'm not going to send you for 100 tests or 5 different x-rays or other studies unless I really think that they're indicated, because I know if I'm going to get one blood test and one study, it's going to be the TSH, we'll talk about what that is, and an ultrasound. So, as I mentioned, the American Thyroid Association is a group of physicians and allied health, so nurses, physician assistants, NPs, and so forth, who are dedicated to taking care of patients with thyroid disease. We have a number of committees, and one of the committees works on guidelines to help guide what we do based on literature review and expert opinion. So almost everything I tell you today is from the American Thyroid Association most recent guidelines. There are many areas in thyroid disease where there is not a clear right answer for everyone. It really has to be tailored to the patient. And another thing I should mention at the very end, that's open and available. Anyone can look at this. If you want to look at these guidelines, they're available online. And sometimes I'll tell patients, if they really are curious, to go and take a look at the data. And at the end of this presentation, there'll be a few links for how patients can get more data on thyroid disease that has been reviewed by experts in the field. Okay, so I mentioned I was going to get a blood test. This blood test is called the TSH. That stands for thyroid stimulating hormone. That is made by the brain, and it is released to tell the thyroid to make thyroid hormone. Okay? It falls into a certain range, and if your thyroid is acting on its own, then the brain signal to the thyroid goes down. If the thyroid is not making enough hormone, the brain signal to the thyroid goes up because it's trying to make your thyroid produce more hormone. Okay? So I always check this number because it tells me whether your thyroid is overactive, that's called hyperthyroidism, underactive, that's called hypothyroidism, or just fine, that's called euthyroid. So knowing whether your thyroid is functioning normally or not will direct the treatment that I give you. It doesn't mean that the nodules within, if you have nodules within your thyroid, it doesn't mean that they're more or less likely to be something worrisome, but it will direct whether or not I'm going to give you some treatment for that over or under function before surgery. So the second study that we do is called a thyroid ultrasound. One is a blood test, the TSH, and then the second test, if I examine your thyroid and I feel a nodule, and as you know, I mentioned quite a few patients have thyroid nodules. If I feel something, my fingers are not as good as an ultrasound. Ultrasound is the best screening test for thyroid disease. The reason is many of the other scans that we do, MRI scans, PET scans, CT scans, those are more complicated, have more exposure risk, and really don't give me any better information than an ultrasound alone does. Ultrasound is non-invasive, and if anyone has ever had an ultrasound, they basically put some cold jelly on your neck. You lay down. It's not the most comfortable when you lay down, but it's not the worst in the world. You basically tip your throat back, and then they use an ultrasound probe and run it over the skin. It has no ionizing radiation. There are almost no risks to having this ultrasound done. And it gives us a lot of information. So let's look at what it does. So an ultrasound can show us what the thyroid looks like. It can show us whether there are nodules in the thyroid or if the thyroid is overall enlarged. It can tell us if there's any enlargement of something called the lymph nodes around the thyroid gland. And it also can tell us the appearance of those nodules. So I don't expect you to memorize all of this. But what this is the American Thyroid Association, their compilation of images with increasing risk that the nodule, the growth in the thyroid, contains something worrisome. And that's how we decide whether or not we're going to biopsy it. And we'll talk about what that involves. So if you look on the very bottom, you see a nice black round hole, right? That actually is a benign simple cyst and is very unlikely to contain a cancer within it. Then all the way up at the top, those are the things that make us a little worried. The size of the nodule is one thing we note. Whether or not there are little calcifications or little white dots inside of the thyroid, if the edges of the nodule are not so clear, and also if there's a difference, it's blotchy looking, that's areas where there's called hypoechoic. All of these things make your physician decide whether or not that nodule is worrisome, and they make the decision about whether or not we're going to take a sample of that. And this is just showing you again the same thing as before, which is we use our suspicion from the ultrasound and all the history from the patient to make a decision about whether or not we're going to try and do take a sample of those cells and make the decision about whether we think there's a risk for this being cancer or not. There's always the potential that we're going to miss something, but we also can't biopsy every single nodule within a patient's neck. We'd be biopsying all day long. So we have to make a rational decision about this. So when a patient like that patient, the 35-year-old woman comes to see me, 2-centimeter nodule, I'm going to get a TSH to see whether her thyroid is functioning normally or not, and I'm going to get an ultrasound. And in her case, the TSH was completely normal, so her thyroid is functioning normally, and her ultrasound showed that she had calcifications, blurry margin, and it was patchy in its appearance. So that made me concerned that this could be a cancer. So the next step is to get something called an ultrasound fine needle aspiration biopsy. So when we talk about biopsying the thyroid, the most common way to do it is by using a needle through the skin. And I'll tell you what the procedure involves. You basically come to wherever you're getting it done, the clinic. You lay flat, head tilted back. Sometimes we'll give a little pinch injection of some local anesthesia, and then we put a needle or a series of needles through the skin using the ultrasound into the nodule. In the past, if I felt a nodule, I just put a needle in. Now we know that we use the ultrasound to be able to tell what area is worrisome or not, so that we make sure we target the worrisome looking area. The ultrasound machine is really helpful because it really can help direct where I'm going. Sometimes people have nodules all the way back in the back of their throat. Sometimes people have nodules like this. It's easy to get a needle into that. But this really makes sure that we target the right area. And there's a lot of pressure, but most people say to me afterwards, the pressure and having the head back was probably the worst part of having the needle biopsy. Part of that material goes off to look under the microscope, and then sometimes we save a little piece to be able to look at the genes that are changed or abnormal in that piece of tissue. You go home afterwards, and sometimes a little Tylenol or ibuprofen can help afterwards with some of the pressure symptoms that patients have. So about 3 to 5 business days later, I'm going to get the results back. And you should know that we used to have all kinds of language that we used to describe what those cells looked like. I would say atypia with cellular predominance. Somebody else would say follicular neoplasm with cellular atypia. The language was very imprecise. So there was a meeting at the NIH, and they all agreed to what's called the Bethesda system for reporting, so that everybody speaks the same language. So there's a whole list of how we describe these, so that when I talk with you and say, oh, it's AUS, atypia of uncertain significance, you understand exactly what I'm saying about the appearance of the cells. Okay, and that's important. So what you hope, of course, is that the needle biopsy will come back as being benign. And I put these images up mostly so that you can see that we do have different categories, and we look at the cells themselves to be able to tell whether it's something worrisome or not. So out of 100 patients, 1 or 2 patients will have what's called an insufficient biopsy. What that means is that there were not enough cells in enough clusters to allow the pathologist to look at it under the microscope and know for sure whether or not it's something worrisome. Right? Now, out of those remaining patients, 70%, the nodule is clearly benign. About 5%, the nodule is clearly cancer. And then there's this wonderful middle category called indeterminate, 20% of patients. The appearance of the cells on the slide alone is not enough for me to be able to know whether or not it's something worrisome. So that skipped right ahead. Clearly I'm talking too long on each of these slides. So we're gonna talk through each one of these categories and how we think about managing patients with these different categories. So if a patient's nodule comes back as being benign, for the most part, 2 centimeters, not abnormal looking we can believe the biopsy results. The data shows that somewhere between 0 and 3% of patients with a benign biopsy, ultimately, if they do go on to have surgery, have a cancer. So those are patients who had a missed diagnosis, very small. Even though that's the data, my personal experience, 13 years of practice, I've only had 3 patients ever with a benign biopsy that the final surgical pathology came back as being a cancer. So you can imagine I do 5 to 8 of these operations a week. My partners, in total, we do about 20 to 25 of these operations a week. So 3 patients in 12 years, 13 years now. It's very unlikely if you have a benign biopsy that there is something worrisome, but not 0. So if I see a patient and they have a benign biopsy, I don't just say, goodbye, it's benign. We have a follow-up plan for how we're going to actually follow you and make sure that nothing changes within that gland. Patients with thyroid cancer, we sort of know what to do. We're going to talk about that. And then we'll also talk about what we do with that indeterminate or middle range category. So let's talk about cancer a little bit. Not all thyroid cancer is created the same. The kind of thyroid cancer you have matters because it changes the likelihood that it's going to come back, that it's spread, and whether or not your family members are at risk for developing it. The most common kind of cancer we see is papillary thyroid cancer. And the vast majority of patients, we have no idea why they developed it. There's no significant family history, there's no radiation exposure. Other than being female gender, we really don't have a lot of risk factors for patients for developing it. So there are a number of variants of papillary thyroid cancer that we worry about a little bit. Follicular variant of papillary thyroid cancer, tall cell variant. We don't need to get into that except you can trust me when you see me that we look at every single one of these very carefully. So the most common kind that you'll hear about is papillary thyroid cancer. Hürthle cell cancer, follicular cell cancer becoming far less common, and we're actually starting to see those patients come in where they already have spread to other parts of their body. Medullary thyroid cancer is a kind of cancer. I actually just helped the AJCC staging guidelines in medullary thyroid cancer write how we're going to stage those patients. And it turns out that there are a number of circulating cell markers that can tell us about that kind of very uncommon cancer, and it's much more common to be familial, meaning run in families. And then the kinds that we worry about in particular are something called poorly differentiated thyroid cancer or anaplastic. Those are the real bad actors. If any of you remember Chief Justice Rehnquist, he had anaplastic thyroid cancer. So let's get back to my patient. We have this 35-year-old female. She has a 2-centimeter left thyroid nodule. I sent her for TSH. It's normal, so her thyroid is functioning normally. But her ultrasound needle biopsy came back as being a papillary thyroid cancer. So what now? Well, as I mentioned, thyroid cancer is common. It's growing in incidence. There were about 64,000 new cases in 2016, far more common in women. But I hope you see this very small line. 98.1% of patients are going to survive from their thyroid cancer. So the first thing I do when I tell a patient their diagnosis is, with proper treatment, you can live a long and healthy life. One of my very last slides will be on myths and misconceptions in thyroid cancer. The most common thing patients hear from other family members or from friends is, I'm going to die from thyroid cancer, or, oh, it's the good cancer. I'm not sure either one of those are very helpful, right? So we talk with them about what our plan is and what I like to say, the chances are very good that in 10 years and 20 years, you will still be sitting with me having a conversation. So they have to understand that with good treatment, many patients can live a long and healthy life. There's always the small potential that this can come back or spread, and we do have some treatments to be able to manage that. And in fact, for reasons we don't understand, new cases of thyroid cancer are increasing over time. One of the arguments that was made is that, oh, you're just doing more ultrasounds and finding more of these. But in fact, we can find it in patients of all ages, even down to 6 months of age. And it's growing in incidence in both men and women. And it's not just those incidental small nodules that wouldn't have been found unless we did an ultrasound. In fact, thyroid cancers of all sizes, except the really large ones, for the most part, we are still finding. Fortunately, many of our patients are able to see a primary care physician on a regular basis. With the exam yearly, the primary care physicians are often able to find these. Many of the patients we see here in the DC area and then in my practice in Boston, patients who hadn't had healthcare coverage or insurance came to us with larger nodules, more advanced tumors, and so forth. So being able to have a routine exam is really important. We went through a lot of this already, but it's just my reminder to tell you it's a very complicated workup and management of these patients. The most simple thing is if you have a benign nodule, we know what to do about that. So what do I do about that lady now? So the first thing I'm going to do is I'm going to feel the lymph nodes in her neck. And why do I do that? Well, everybody has lymph nodes all over your body. It's a normal part of your body. But when lymph nodes become enlarged, they're a little bit more worrisome, especially in a patient who's known to have thyroid cancer. So I'm going to feel for lymph nodes within the neck and the other parts of the body. But then I'm also going to send her for an ultrasound. And the ultrasound, again, will show me if there's any worrisome-looking lymph nodes on the side of the neck, because 1 out of 5 patients, by the time they come see me, already has spread to the lymph nodes of the neck. So it will change my surgical approach for her. And that's just a reminder to tell you that we feel the lymph nodes in the center of the neck, and we feel the lymph nodes on the side of the neck. Those are two completely different areas. Believe it or not, there's a whole barrier between the two of them. And at the time of surgery for the thyroid, I can remove or look at the lymph nodes in the center of the neck. But if the ultrasound doesn't show me anything in the side of the neck, I'm not going to go out there. We don't go looking where we don't need to be. Okay, we say, don't poke a skunk. So we don't go looking in the side of the neck unless it's obvious that there are worrisome looking lymph nodes out there, and we have to know that they're involved. And we make a decision based on how the ultrasound looks, whether or not we're going to biopsy those lymph nodes, because I need to know before surgery whether or not there's involvement of the lymph nodes on the side of the neck. So, top to bottom, every one of these things is in flux about how to take care of patients. Okay? We know now that ultrasound-guided needle biopsy is really important and helps take care of patients. We're still debating how much surgery to do, and we're going to talk about how I approach surgery for her. Whether or not we take out some lymph nodes that don't appear to be involved, and if it's going to change how you do. And then whether or not you're going to get treatment afterwards, what kind of treatment you're going to get, and how do we follow you long-term, all kinds of interesting things about how we follow patients. So it used to be sort of a one-size-fits-all. You have thyroid cancer, you're getting your whole thyroid out, you're getting radioactive iodine, same follow-up. Very different now. We change how we follow patients and what we offer them for surgery based on how big the tumor is, what their family history is. If you had your thyroid removed and there was no evidence of lymph node involvement, we may not offer you radioactive iodine, and we may follow you much more closely every 6 weeks, 8 weeks, 3 months, 6 months, ultrasound, whole body scan, all kinds of things based on whether your lymph nodes are involved and you get radioactive iodine or not. So I'm going to adapt my plan to you rather than say, here's what you get done because you have thyroid cancer. It's much more of an emphasis on taking care of the patient now and avoiding having anything come back in the future, rather than just sort of over-treating patients and hoping it doesn't come back. It's really very tailored to everybody. And this would be a very different patient, right? 35-year-old male, bigger cancer, found on routine physical exam again. And when I looked at his lymph nodes, he had lymph node involvement. So he's going to get a different approach, different treatment than my first patient. And we use a whole group of people. So we have a meeting every Tuesday, 15 of us get together. We talk about how we manage patients with thyroid disease. We present patients at that. Well, we present the case. The patient themselves doesn't come. But we present that case at our thyroid cancer conference so that the oncologist, the endocrinologist, the surgeon, the radiologist, the pathologist, everyone gets together to talk about the patients and decide how you're going to take care of them. And we're all very used to picking up the phone and talking with each other. So that patient got referred to a surgeon. So what do I do? Well, I take care of patients with thyroid disease, right? There's a couple surgical pictures here. Nothing too gory, I hope. I left all of the real patient pictures out. We take care of what's called parathyroid, which are little tumors next to the thyroid gland. We operate on patients with pancreas problems, where the endocrine tumor in the pancreas is growing. And we take care of a little tumor on top of the kidneys called the adrenal glands. All of these make hormones that circulate in your bloodstream. So I think as an endocrine surgeon, I take care of the whole patient because I'm taking care of tumors that affect the patient's whole body. Just a single slide on me and our us and our program. So we're incredibly busy in taking care of patients with thyroid disease. We're probably within the top 10 in the United States for treating patients with thyroid cancer. We have a very busy and active group of endocrinologists and a very busy nuclear medicine group. We have a weekly tumor board where we get together and talk about complex or interesting patients. And then we operate on patients with thyroid, parathyroid, and adrenal issues. I have 2 partners, Erin Felger, Nancy Carroll. I've known both of them for many years. And we have a nurse, Diane, who's wonderful and has been with us for a long time, and an office staff that is very helpful in helping guide patients through this complicated process. A little bit about how I got to do what I do. So I went to 4 years of college, 2 years for a master's, 4 years of medical school, 5 years of surgical training, 3 years of fellowship, So I was 35 before I, A, owned my own house, and B, started to actually practice medicine, practice surgery. So we have a lot of training behind what we do. And yet, 13 years in practice, I still feel like I learn all the time, which I think is good because there are a lot of questions within what we do. The three of us practice as a group. We're in and out of each other's operating rooms. If there's ever a question, there's always someone who can help me. So a very collegial group, which is nice to work with. So back to the bedside. So what is that 35-year-old female? What are her options? Well, she could have watchful waiting, do nothing. Thyroid cancer, 2 centimeters, they're slow growing. I wouldn't recommend that because we know that these tumors can grow and spread to other parts of the body, and there's no evidence that that any other kind of medication or treatment really is as effective as surgery. And then she has the option of surgery. She has really surgery, 2 choices: removal of half of the thyroid gland with a little piece of the middle portion, or removal of all of the thyroid gland. Right? We don't just pluck nodules out of the thyroid. They're like bubbles in bubble bath. You can't separate them from the thyroid. And it's the margin or edge of the nodule that really makes the difference as to whether or not we are going to treat you with additional treatment. The thyroid doesn't like to have bits and pieces taken out of it. The other thing is that we're very good at replacing thyroid hormone. So if you're going to have surgery for thyroid cancer for a significant tumor, meaning over a centimeter, centimeter and a half, you should consider having the whole thyroid gland removed. We still debate this a little for the smaller cancers, 1 centimeter or so. Maybe a lobectomy alone and watchful waiting is enough for patients. My argument between the two of them is, I can't monitor your blood tests after surgery to know if you have recurrence. It's difficult to treat you with radioactive iodine. And we know that these can be multifocal or in more than one location. So a total thyroidectomy, removal of the whole thyroid gland in the hands of someone who does a lot of these operations, is fairly low risk and will give you the assurance that you've done everything you can to treat that thyroid cancer. So in select patients, part alone is okay, but for most people, the whole thyroid gland should probably come out. And then again, as I mentioned, we're going to look at the lymph nodes, both in the side of the neck and the center of the neck. So I promise you no real gory operative pictures. If you want some of them, come to me and I'll show you some pictures later, or just go to YouTube like all my patients do. So I have a lot of patients who come in and they say, I saw you do surgery. And I said, no, you never saw me do surgery because I don't post on social media my patient. There's something called HIPAA. We don't post any of the patient information. And all the patients you see here, there's no identifiable information. I don't tweet. I don't Facebook. I don't do any of that for my personal patients, but all my patients get my email address. So this is how we position a patient for surgery. Head back. You're completely asleep for the operation. I put a tube in to breathe. I numb up your neck so that when you wake up, most people tell me the incision doesn't hurt at all. The throat is sore from having the tube put in to breathe, and that lasts for about a day. And then I make a small incision in the middle of the neck. Usually my incisions are about 1 inch. And then we take your thyroid gland out, whatever portion we agreed to. Send it off to pathology, 3 to 5 days for the final results to come back. Close the incision with multiple layers of stitches, a little bit of glue, 1 night in the hospital, home the following day. If you chose a total thyroidectomy, I'm going to start you on thyroid hormone the day after surgery. Tylenol, Motrin for pain, no narcotics, nobody needs them. Can't tell me that I'm responsible for any of the opioid crisis. I haven't written a prescription for narcotics in about 13 years. And then calcium in the form of Tums, and I'll explain to you why I do that. Operation takes about 1.5 hours, not including time to go to sleep and wake up. It's a 92-year-old lady I operate on. That's 10 days after surgery. You're welcome to look for her scar later. That's a 50-year-old lady 3 months after surgery. Okay? So it's not like the old-fashioned incision. Sometimes we have to make a big incision. And I tell my patients, I make it as small as I can, but as big as it has to be. So we know all kinds of tips and tricks to make the skin heal well, but for the most part, people do really well with this. I might have chosen some particularly good incisions to show you, but And this is what the tumor actually looks like. So it's like a nodule within the thyroid gland. You hope that it would look normal, but in fact, it looks like papillary thyroid cancer. So now you can look at the whole specimen, any lymph nodes that you removed, very carefully under the microscope, section it in 1 millimeter pieces and look at it very thoroughly. I don't do frozen section in the operating room, which means I don't look at the specimens immediately, except under rare circumstance, mostly because you're just cutting the piece in half and looking at it. I send it off and let my pathologists do their job. 1 millimeter sections, very complete in their evaluation. A word about robotic surgery and laparoscopic surgery. I come from the modern era. We do a lot of things using the camera and laparoscope and robot. Thyroid surgery doesn't need to be one of those. The incision is tiny. Some other places in the world, some other places in the US, they make an incision underneath the arm to approach the thyroid gland, or over the nipple to approach the thyroid gland, or behind the ear, or the latest thing is to try an incision through the mouth, all kinds of approaches. My personal feeling about this is, if you can show me it's better for the patient, that it makes sense, it's cost effective, but the most important thing is it better for the patients? Is it cost effective, and do you get all the tumor in the same way that you can do it through the old-fashioned approach? And by the old-fashioned approach, you saw my incisions. I'm a big fan. Until then, I'm going to approach surgery in the way that I think is the best for you. Now, we are fully able to do robotic surgery and laparoscopic and minimally invasive approaches to this. So we're going to let that be for now. Don't let the cart get before the horse. Make sure the operation is safe and it's the right one first. So this is what we think about when we think about surgery. I think about, did I do a good job? Did I take all the cancer out? Did I leave them with a nice looking scar? And what did I do when I was doing surgery? So these are the risks of surgery. In order of importance are bleeding. I've had 8 patients bleed in 12 years. Bleeding usually happens within an hour after surgery. Patient has to go back to the operating room. Infection, I've never had a neck infection. I've seen one ever. They're incredibly uncommon. Changes in the voice, and we'll talk about that a little bit. There are 2 nerves that go to the vocal cords that come from underneath the gland and 2 from above that help regulate the upper and lower part of the voice. So when I'm doing my dissection, I'm always telling my residents and students, and by the way, you should know I have residents who are in their training, and I have medical students who come with me. I'm from an academic institution. I only have 2 hands. I need at least 4 to 6 to do this operation. So I'm there from beginning to end and taking care of the patients, and I only operate on 1 patient at a time. So we're not running multiple rooms at once. My focus is on the patient I'm taking care of. So whenever we're doing our dissection, I always remind my resident that, be very careful about what you're doing, or that person will never sing in church again. So I always think about how we take care of every one of these complications and make them as small as possible. So voice changes because you can have injury to those nerves that run underneath the voice box. And then the last is permanent low function of those little glands that live on top of the thyroid, called the parathyroid glands. They make a hormone called parathyroid hormone that helps regulate the calcium level in your blood. And so the calcium level can go low and permanently stay low after surgery if 1 or more of those glands comes out or all 4 of them are injured. And then you have to be on large doses of calcium for the rest of your life. About 1 in 100 patients has a permanent change in their voice, and anywhere from 3 to 6 out of 100 patients has permanent low function of those little glands. And then you may consider the need for additional surgery to be a complication. I actually don't. I do the best operation as the first operation, but people can have recurrences after surgery. So, Apparently it wants me to stay on the post-op complication slide for another minute. See if I can get that to move forward. Oh, there we go. Now it wants to go too fast. There we go. I mentioned to you we use this special kind of monitoring. So in the past, the way that we looked for the nerve that goes to the voice box is by using just my intuition. There are a couple of other techniques to use. One of them is this system. And as I mentioned, I have no conflict of interest, so I'm not promoting any one system or another. This happens to be one system that we use. And basically what we do Very good. Is we use the special tube that we put in the back of the throat, and whenever the vocal cords twitch or move, it hits the tube and it makes a lovely ping sound. So I'm stimulating the nerve with a little probe, and when I stimulate that nerve, it makes the vocal cords contract and it makes the lovely ping sound. That's what I use in the operating room. I like to use my common sense to know what the nerve is and then use this to confirm what I already know. It also tells me whether or not the nerve is functioning properly. Very helpful to know when I make the decision about how far to go with surgery. So what should you expect, or what should patients expect? Most patients go home within a day. Some even go home later that evening if they feel really wonderful. They're going to go home on thyroid hormone, calcium, and then ibuprofen, acetaminophen. Little pain, it's more neck discomfort. And really most complications happen within the first 24 hours. So the pathology will come back in about 3 to 5 days. We'll go over the final results. We'll know what the next steps are, and we do something called staging. So how do I know how advanced your tumor is? Well, we'll get to that on our next slide in a minute. They're going to come back to see me and their endocrinologist for post-op. I'm going to check their blood levels to make sure I'm giving them enough of their thyroid hormone. And in fact, we give a little extra thyroid hormone to help keep the brain signal to the thyroid a little below normal. And then I'm going to check some circulating levels to see whether or not we think you have a thyroid cancer that has recurred or spread to other parts of the body. And I'm going to follow up. We're going to have a whole follow-up plan. And I love it because I get to follow patients for life. Next slide. So patients say, how far along was my thyroid cancer, and why don't you know before surgery? Well, the reason is we need to know if the lymph nodes are involved, and the only way to know if the lymph nodes are involved sometimes is to take some of the lymph nodes in the center of the neck or side of the neck out. So we do things by what's called the TNM staging. T, tumor, N, nodes, M, metastases. And staging determines prognosis. That means your staging will let me know the likelihood of you living a long and healthy life, and it will tell me how much treatment to give you. And it's also based on your age. Patients over 55 and under 55, we do different staging, and the type of tumor matters as well. Next. So there are 2 basic principles for long-term management: radioactive iodine, if indicated, and what's called TSH suppressive therapy. So I'm going to give you a medication to keep the brain signal to the thyroid low, and I might give you some additional treatment called radioactive iodine. Not everybody gets it, but we give it to you if we think you're at high risk for recurrence so that we can try and avoid having you recur. Okay. So that patient that I presented to you earlier, she had a thyroid cancer. She had a total thyroidectomy. We removed the lymph nodes from the center of her neck. She had no evidence of lymph node spread. The thyroid cancer was well contained. We kept her TSH suppressed, and she did well. So now let's talk about that wonderful indeterminate group. So this is a patient very similar. I basically cribbed off of my old patient. What if her nodule biopsy had come back as that indeterminate category, where you can't tell if it's a cancer or not? It's this wonderful category called follicular lesion of undetermined significance. Go ahead. So, as I mentioned, we have this language, and we use this language to be able to decide amongst ourselves what the risk of it being a cancer is. So with increasing risk or increasing worrisome, the likelihood it is a cancer is greater. No CT scan, PET scan, elastography, genetic studies can tell me with 100% certainty whether or not this is likely to be a cancer. So in her case, she had this thing called FLUS, follicular lesion of uncertain significance. That's somewhere about 5 to 15% likely to be a cancer. So before we had any other kind of approach, that patient would have had surgery for the purpose of diagnosis, not for known cancer, okay? And 85% of the time it would have been completely benign. Now imagine you're the patient, you have surgery for diagnosis, and let's say you have one of the complications of surgery, and it turned out to be benign. How would you feel about having had that diagnostic operation? Versus if I only removed half of the gland, or you opted just to have watchful waiting, and it turned out to be a cancer and grew or spread. So wouldn't it be nice if you had a test that could tell you for sure if it was a cancer or not? Okay. Right. Wouldn't it be nice if you could avoid surgery for patients with thyroid nodules who don't have cancer, and you can tailor surgery more carefully for people who do? Go ahead. Now, you should know, thyroid surgery, the history of thyroid surgery is the history of surgery, starting with Dr. Coker, who developed many of the surgical techniques for taking care of the thyroid. Dr. Bill Roth, who had a huge surgical volume, was a great teacher. Dr. Halsted, who developed all of the surgical instruments we use and in fact wrote the first thyroid goiter book. So the history of surgery is the history of thyroid surgery. The 2 or 3 most common surgical conditions in history were enlargement of the thyroid gland, swelling in the brain, and hernias. And the 4th was actually breast cancer. Those are the 4 things that were most commonly treated with surgery over the years. So to answer the question of trying to figure out who does or does not have cancer, a variety of genetic studies were developed. I'm just going to tell you very briefly about 2 of them, but there are a variety of them on the market. So one of them is called the Afirma gene test, the Asuragen test, or we could say the Veracyte test. And what they basically do is, without going into the detail of it, they look at the genetic pattern of the tumor itself to be able to tell if it's a cancer or not. And if it comes back as being suspicious, that raises the likelihood that that nodule is cancer to between 30 and 40%, not 100. And if it's negative, it drops it down to what the benign biopsy would have shown, which is between 0 and 3%. Okay? So imagine you're a 35-year-old woman with young kids and a very active life, and you have a 2-centimeter nodule, and your needle biopsy come back as FLUS, and your doctor recommends surgery for the purpose of diagnosis. 5 to 15% might not be enough for you to want to have your thyroid gland out. So sometimes we perform these gene tests to try and push us closer in one direction or another, follow-up or surgery. You just have to understand it's not 100%. And this is just another example of one of the tests that we use. And there's a whole series of others without going into the brand names of any of them. I'm going to skip through this a little bit. This is a technique that my lab developed using basically called elastic scattering spectroscopy. It's very simple. It's 2 fibers side by side. One sends out a broad spectrum white light. The other looks at what bounces back to it. It's like a flashlight in the dark. What bounces back to your eyes is what you see. So the road looks different than a tree, looks different than a fox, or something like that, right? Same thing in the thyroid. When you put the needle in, cancer looks different than benign. And this is a technique that my lab is working on developing. And those are the probes, very tiny. You can keep going. This is just the fingerprint of each different kind of tumor looks very different. Okay? And then we have developed techniques for making a test to be able to do at the bedside. So I can tell you with a high degree of likelihood whether or not you have a cancer in very real time instead of having to wait 2 to 3 weeks. So that patient with that indeterminate nodule needed to have surgery for the purpose of diagnosis. So we did a lobectomy, removal of half of the thyroid gland for that patient. It turned out to be a cancer, and that patient came back to have the other half of the gland removed. And it turned out that there were a couple of lymph nodes involved, and that patient went on to have radioactive iodine. So one more important thing. So in addition to all of the technical parts of what we do, we also know that the more you do of something, the better you are at doing it. And so this is really where a lot of the research is going now, is looking at quality measures in thyroid cancer and taking care of patients with thyroid disease. We know that the more you do of an operation, the better you are, but sometimes it's just being able to do a lot of a very complex operation and period is better. And having a group or a multidisciplinary team who all get together and talk about patients might be better than people practicing, you know, this person practices here, that person practices there. So having a group that actually talks to each other and coordinates your care is probably the most important. Believe it or not, so I told you our surgical volume. You know, we do about 20 to 25 of these operations a week. In the United States, most thyroid cancer is treated by people who only do 3 to 5 of that operation in a year. So, you know, it's really important that people in various areas of the country have easy access to care, so they don't have to feel that they have to drive an hour, 3 hours, 5 hours, 12 hours in Maine or Alaska or other places to get good care. But we also know that surgical volume and experience really matter. So how do you balance those two? The first thing is, as a patient, you have to ask how comfortable your doctor is in taking care of it, and you have to be certain that they know how to take care of you, not just the disease. I could have presented any one of these. These are all patients that I've seen. 89-year-old patient with a growing thyroid nodule, totally functional patient. No reason because of age to say that I'm not going to take care of them. Down to the patient who's already had a total thyroidectomy, a central neck dissection, lymph nodes from the side of the neck removed, radioactive iodine, and now they have a recurrence. So we take care of patients the whole spectrum, and everybody needs the treatment that's really the best treatment for them. And this is our goal, right? Improve our ability to tell who has a cancer or not, target the treatment just to the patient, make the complications as few as possible, and make sure that you're going to live a good quality of life. I practice yoga. I tell my patients not to do this. This is the position that brings light to the thyroid gland. My favorite position. Next. We have a group, we give medical lectures all the time. We talk about scary thyroid cases and scary endocrine cases. There's a lot of people in this area who are very comfortable treating endocrine disease, and it's just a great opportunity to talk about complex patients. So I'm just going to wrap up by saying I hear lots of myths and misconceptions all the time about thyroid cancer. I'm going to leave that up for a moment or two so you can see them, and then my presentation will be on the web, I think. But we hear all kinds of things from patients. The most important thing is that patients get evaluated, you get the right treatment for you, and then you follow up. And many of my patients need follow up for life because you can have recurrence from thyroid cancer 10 or even 20 years later. And the last two slides I'm going to close with are from the American Thyroid Association. There's patient portal with all kinds of web information that you can print out from a really reliable source. And you can click on any one of those. We even have a clinical thyroidology for the public, where we take articles that are being published and translate them into language that patients will understand, because I think that the decision-making is changing so much in how we treat patients. You really have to stay up to date. And THICA, which is the largest thyroid cancer survivors group, very active in getting patients involved also. And that's just more information about the ATA. Lots of different venues for you to find out information about thyroid disease. So I'm going to close there. I'm going to take questions, but first I just want to say thank you very much for being patient and listening to me talk about what it is I do and how we think about taking care of people. And I'm more than happy to answer your personal questions. We can either do it now or we can do it separately. And I hope that you all learned a little bit about what I do and how I think about it. So thank you. Any questions? No questions. Anybody here have a patient who is, have a patient, sorry about that. Anybody here have a family member who has ever been treated for thyroid cancer or thyroid disease?
Not thyroid cancer, but some kind of disease. But I do have a question. What type of, maybe I missed it, but what types of symptoms do you have?
Almost none. The vast
Really?
majority of my patients who come to see me have no symptoms at all.
Okay.
Right. So you have to divide patients into patients with thyroid nodules and patients with over or underactivity of the thyroid. So patients with thyroid nodules often feel nothing until somebody points it out to them. Patients with thyroid symptoms with the over or underactivity, when you have overactivity of the gland, commonly people will say, I lost weight, I'm sweating, I'm nervous, I have palpitations, I don't feel well, I have hair loss. Believe it or not, overactivity, sometimes people gain weight, don't lose weight. Everybody thinks you lose weight, sorry. Hair loss and a whole variety of things. And then underactivity presents in typically, you feel cold all the time, maybe hair loss again, issues with fertility. There's a whole variety of ways that patients present.
Thank you.
You're welcome. I'm sorry, do you mind? Or speak up. No, to come to the microscope or speak up a little bit for me.
You were saying something about the thyroid nodules. Oh, you were saying something about the thyroid nodules. Is that what symptoms do you have with that?
Many patients have no symptoms at all. I have patients who come to see me who have thyroids like this. It doesn't bother them at all. And then you can have a patient who has a 1 centimeter thyroid nodule and it drives them crazy. They feel pressure or they feel a lump in the back of their throat, or when they swallow they feel that something is in the throat. The other thing that I see sometimes is that patients, when they lay down for sleep, feel that they have pressure or compression in the neck or can only sleep in one direction or another. But you can have large thyroid nodules or even thyroid goiter. Goiter is an enlargement to the thyroid,
That's
and have
two
no
different
symptoms
things.
at all. No. Thyroid nodules are single nodules, like a little lump or growth. A goiter usually is either overall enlargement to the thyroid gland or multiple nodules. Like I said, like bubbles in bubble bath. You can't separate it from the thyroid. Goiter means shield, and it refers to enlargement to the thyroid gland.
Oh, okay.
So when somebody comes to see me with 1 nodule, technically that's called a uninodular goiter. If somebody comes to see me with multiple nodules, that's called a multinodular goiter.
Okay, thank you.
Yes.
Actually, I have 2 questions. One was, did you say something about the kidney and parathyroidism or something? Could you talk a little bit more about that?
Sure. So as an endocrine surgeon, and really endocrinologists do this too, we see patients who have growths or enlargement of other glands in the body. Some of those that I treat are enlargement of what are called the parathyroid glands and what are called the adrenal glands. So the parathyroid glands are glands that live on the thyroid. Most people have 4 of them. They're the size of a grain of rice, blood supply the size of a human hair. If they enlarge, they make more of the hormone that they produce, and that hormone is called parathyroid hormone. It helps regulate the calcium level in your blood. So typically what I'll see is I'll see a patient who comes in who either was noticed to have high calcium level in the blood, or, and I give a whole talk on this, or other reasons made their doctor look for abnormalities in those parathyroid glands, and sometimes we have to operate on those patients. The other kind of tumor is called an adrenal tumor. Those are glands on top of your kidneys. They make a whole variety of hormones, and the hormones that regulate sex drive, sugar control, salt control in the body, a whole variety of things. When they enlarge, they can make hormones. They can be functional, and those hormones often cause dysregulation, things in the body to go wrong. So very often we'll see patients who have what we call functional tumors of those adrenal glands. The other thing that we sometimes see is cancers of those glands. Cancers of the parathyroid are incredibly rare. I've seen 3 ever. Cancers of the adrenal, unfortunately, are a little bit more common. So we look to see if those adrenal glands are making too much hormone or if they're worrisome for being a cancer, and those patients need to have surgery. So as an endocrine surgeon, I treat all of those.
Thank you. I have one other question.
Yes.
Have you seen any correlation between sleep apnea and thyroid problems?
So yes and no. So you have to look at the Venn diagram, right? Lots of people with thyroid disease, lots of people with sleep apnea, lots of people with both sleep apnea and thyroid disease, but I don't think there's good evidence that one causes the other, okay? And in patients who do have sleep apnea, we're particularly careful to make sure they're monitored overnight after surgery because the risks of anesthesia are a little bit higher in those patients. The flip, though, is true, which is people can have snoring and trouble breathing from large goiters, but it's not necessarily sleep apnea. The neck can hide a lot of things. Some people with goiters, it likes to grow out in the neck. Some people, it likes to grow down, and it can get into the chest, and you can get tumors this big in the chest. And I've taken them out, size of a cantaloupe, down in the chest, that they never had any symptoms until they had to get some procedure done, get an x-ray, and you see a huge substernal goiter. So sadly, if sleep apnea and goiter were completely related, I would be way too surgically busy.
So
Yes.
I have a question. Is there possible that it causes your eyes to bulge, or is that something that my mother had? Something
Yes.
similar to that. So is that also related?
There's two reasons why that can happen. So in patients who have overactivity of the gland, it's a disease called most commonly a disease called Graves' disease. So in Graves' disease, patients are making an antibody against the TSH receptor, and the thyroid gland goes large. Behind the eye, in the fat pad of the eye, you also have those receptors. So technically, the eye itself is not growing large. It's inflammation of the fat pad behind the eye that makes the eye stare forward. So the overactivity of the gland can often cause that. The other thing that can sometimes happen in people with really massive goiters or substernal goiters, you're compressing the blood supply. And so those patients can come in and the face is puffy and full because the blood supply draining the brain and the face is pushed to the side by the goiter. So it's not uncommon for me to take that out and then sort of everything, goes back to normal. See, I love questions. These are good.
I have two questions. The first question is on blood test. If
Yes.
the blood test related for my thyroid from the annual checkup is normal, is that sufficient?
So I always seem to have two sides to every answer, but there is. So it depends on why you're coming to see me. If you're coming to see me because you have a thyroid nodule, I'm going to check. Many people will check the TSH alone. Sometimes we'll check what's called the whole thyroid panel, where we'll look at what's called the T3 and T4. The first and most important screening test is the TSH. That's the brain signal to the thyroid to make hormone. If you're coming to me because I think you have over or underactivity of the gland, I'm going to get the whole panel. I'm going to look at the circulating level of hormone as well, called the T4 and T3 levels. That will tell me not just what the brain signal to the thyroid is, but whether or not your thyroid is making hormone and how much. Is it too much? Is it too little? Are you having trouble converting one form to the other? But as a screening test, the TSH is the only and the first most important that I need to check. The other thing is that T3, T4, those levels, the circulating level of hormone, that can change very quickly. The TSH, the brain signal to the thyroid, usually takes a little bit longer to change. So it's a longer picture of how your thyroid has been functioning. Okay? If you're going to see an endocrinologist because you think your thyroid is over or under functioning, they most likely are going to get the whole panel, including the TSH, T3, and T4. And on the ATA website, there's all kinds of pamphlets and brochures about hypo and hyperthyroidism and how we treat those.
Thank you. And my second question is on one slide in your presentation.
Yes.
It's on that position from yoga. I just want to make sure I understand, is that not recommended for people with thyroid, diseases?
So no. So first, that's not an official statement. That's just my personal feeling about the yoga position, and maybe I was being facetious in that. That position is, from my very small understanding of yoga, my practice of yoga, is it brings light to the thyroid gland. That's what the position is called. I don't know the name of that position, but I tell patients, I was more facetious in saying that. There's no recommended yoga positions for or against for patients. And in fact, I'm a big believer in yoga and Pilates and exercise for my patients. As far as I'm concerned, you can exercise within a few days after surgery, but there's no recommended positions for or against that are particularly for or against your thyroid health. The more people practice yoga, the happier I am.
What's your recommendation for thyroid health?
Meaning,
Like
in general,
Yes.
a good balanced diet, 8 hours a night of sleep if that's what you like, and seeing your doctor on a regular basis. That's my recommendation.
That's it.
Yeah, that's pretty much it. I did a national survey looking at supplements in patients with thyroid disease. I could describe to you what people use. I personally think a good balanced diet is pretty much all you need. I don't believe that any combination of vitamins or minerals or exercise or anything is going to keep your thyroid any better or worse than it naturally is going to be. Which brings me to one word about thyroid hormone. So I'm a surgeon, right? I don't prescribe anything. I give you your first 30 days of thyroid hormone, then you go see your endocrinologist. So, I get patients ask me all the time after surgery about what form of thyroid hormone should they be on. I don't have an official position, nor do I believe the ATA does, recommending for or against any particular form of thyroid hormone. But the vast majority of my patients just take one pill a day and feel completely normal, or believe me, I would hear about it. I hope that helps. Not sure if it was what you were looking for, but it's true. See you, doctor. Any other questions?
So is there a tie to, I have hypothyroidism, to a vitamin D deficiency?
Okay, so vitamin D deficiency is incredibly common, and it's particularly common in the northern hemisphere, in areas that don't get a lot of sunlight. So your skin metabolizes vitamin D to its active form. Vitamin D helps you absorb calcium in your diet. And if you're vitamin D deficient, then many patients will say they just don't feel right, they're tired, they're fatigued, aches and pains. Sometimes the calcium's not normal, sometimes the calcium's perfectly fine, they just don't feel well. Okay? A low dose of vitamin D supplementation if you're deficient is a good idea. Some patients need a little bit more, a little stronger form of vitamin D because they just can't absorb the normal form. Patients with something called thyroiditis, which is inflammation of the thyroid gland, the most common being Hashimoto's thyroiditis. The parathyroid glands live right next to the thyroid gland, and so the thyroiditis can be irritating to those glands. I know that's not the scientific way of saying it, but it's true. And so you can sometimes have low function or over function of those parathyroid glands. Vitamin D deficiency makes it particularly more sensitive. There's no known cause, as far as I know, there's no known causality between vitamin D deficiency and low function of the thyroid. The only reason they're related is because the glands live right next to each other, and those parathyroid glands are just more sensitive to vitamin D deficiency. Now, the flip, of course, is true. People with hyperthyroidism or overactivity of the thyroid gland, sometimes the parathyroid glands become overactive, and then the calcium level can rise in the blood also. And vitamin D deficiency is important there because it can contribute towards making you develop a tumor or growth. It can be irritating to the glands. It can be associated with worsening of that what's called hyperparathyroidism. So when I see patients, I'm going to check their vitamin D level, and I'm going to check their vitamin D level because if they're going to have surgery, I like the vitamin D to be close to normal because my thinking is that it makes those parathyroid glands a little bit less sensitive to being touched or manipulated during surgery. But there's no known causality between vitamin D deficiency and hypothyroidism. They're very common, and many patients have both of them. Again, it's really important what I do to remember that things are common, but they're not necessarily related or causal.
And I also, I feel like I suffer from memory loss a lot. Is that one of the symptoms of thyroidism?
So, memory loss. So, I'm not so sure with thyroid disease, although really severe low function of the thyroid that isn't being replaced properly can cause memory fog and forgetfulness. What I often see in patients with primary hyperparathyroidism, over enlargement of one or more of your parathyroid glands, is that patients, when the calcium level starts to go up, then they get mental fog, fogginess, confusion, and that often can be linked to overfunction, that high calcium level. And the vitamin D deficiency, it doesn't cause it, but it can make postoperative low function a little bit greater. So if somebody comes to see me and I check the calcium level, it's high, I check the parathyroid hormone level, it's high, we do the workup, they're going to have surgery, I'm going to correct that vitamin D level. And then people typically have a constellation of symptoms, and that constellation of symptoms includes mental fogginess. And if we correct your problem with surgery, that mental fogginess can get better. So there's a whole sort of interrelated series of these things. It's very hard for me to say for sure if the mental fogginess is from the disease until we see whether or not if we correct it, it's better. Hypothyroidism alone is not an indication for surgery. And Hashimoto's thyroiditis or thyroiditis alone is not a reason to have surgery. Nodules in there that are worrisome are a reason to have surgery. And it's not uncommon for someone who's had long-standing thyroiditis and nodules and has surgery to tell me they feel better afterwards. But I don't want to hold out any thinking that we operate for hypothyroidism. Mm-hmm. Again, there's a whole group of patients I do not operate on.
Thank you.
Does that answer your question?
Yes, ma'am.
Good.
What is there a normal number rate for a thyroid, perfect, normal acting thyroid?
Is there
a number?
Oh, a number. So every lab has its own number, but the TSH is usually between 0.45 and 4.5. It's international units per milliliter. So there's a range, 0.5 to 4.5. A lot of people have feelings that maybe you shouldn't live up by 4.5. It's uncommon. It's a little like the temperature. Almost everyone in this room is going to be 98.6, okay? A few people might be 98.59. A few people might be 98.61. But for the most part, for the enzymes in your body to work, you're 98.6. For thyroid, there's a little bit more of a range, and we really like to keep you in that working range. The problem with thyroid disease, of course, is so many symptoms from thyroid disease. We'd love, every so often I think, boy, my fatigue, I really wish I could take thyroid hormone for my fatigue or weight gain or hair loss or any of those. And unfortunately, it's not necessarily a cure-all. Yeah.
Hi. So I just want to follow up on the question she asked and the gentleman asked over here about overall thyroid health. So
Yes.
she'd asked if sort of the normal workup that you get when you have your annual checkup is sufficient, and you mentioned going to an endocrinologist. So is the answer no?
So let me take a step back. Going to your primary care physician, having a primary care physician, and going to your primary care physician every year for a checkup is important. That's their training, is to know how to make sure that they're doing the appropriate tests for you, asking you all the appropriate questions, and then doing lab work that they think is indicated, okay? So if you go see your primary care physician, most of them are going to ask you questions about thyroid over or under function and get a sense of how you're feeling. If you tell them, I'm fatigued, I'm losing hair, or I'm hyperactive, I'm sweating all the time, I got palpitations, most of the time, and there are guidelines for them to follow as well, are going to check a fundamental thyroid panel. They'll do a thyroid panel. Many of us get a yearly lab work done. And part of that, if you report symptoms, is to check a thyroid panel. And then they will use that as a guide as to whether or not they are going to evaluate you further, or if they're going to refer you on to an endocrinologist. Not all patients with thyroid issues need to see an endocrinologist. Many of them can be handled by your primary care physician alone. I personally, there are a lot of people who would love to take your money and do a panel of 100 different tests and do all kinds of skin tests and have you take a particular cocktail of vitamins or minerals or whatever. Plenty of people would be happy to take your money. I don't see any evidence that buying a $1,600 pack of vitamins and minerals or getting a 175 gene panel to see what you're more or less prone to is going to make you healthier or find more. That you're always going to find something to treat. So I would caution you that beyond just your regular primary care physician, and you have to feel like you have a good one that you have a good relationship with and you can have a good conversation with them. Beyond that, I don't see that there's good evidence that you should be taking supplements or getting any additional tests or treatment. Now, in between your office visits yearly to your primary, you might start not feeling well. Something can change. You need to call them and you need to be able to get seen if you're not feeling well.
So there aren't any, like, I guess, key symptoms or things that you would want to request that your thyroid be checked or that you be referred to an endocrinologist at all?
So if you go to the ATA, there's a little guideline to that. And there's also, I think on the AAF, the American Association of Family Physicians, there's a couple other things, what to ask or what to talk with your physician about during your yearly visit. And there's at least 3 or 4 screening questions for thyroid disease on that. So they'll typically ask you questions. As I said, the thyroid regulates everything: hair, skin, heart rate, metabolism, weight. All of those are screening tests that they're going to ask. And when you go to their office, usually there's a whole screening list of symptoms that you check off. Have you experienced this, that, or the other thing? And you need to answer that as best as you can. I mean, people come to see us in a whole variety of ways. One of the ways that they come to see us is because they notice something, and one of the ways they come to see us is because their primary checked something when they were evaluated. I mean, I'm a surgeon, right? So there's a selection bias there. If you had an endocrinologist here, they could tell you a little bit more about that upfront screening for over or underactivity. we tend to we operate on overactivity of the thyroid, not so much underactivity. And they would probably, maybe that would be another good conversation to have. That's kind of from the surgeon's point of view. That's from the surgeon's point of view. And a patient myself, right? I mean, I've had 3 kids. I've been a patient. Any other questions? I take vitamin D every day, just FYI. Can't hurt. All right, great. Thank you.